Now, today we are going to learn about physiology of pain. According to the International Association for the Study of Pain, or IASP, there's a definition for pain. What is that? It is an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage, or described in terms of such a damage. So that is the definition of pain. So when you talk about pain, there are many classifications. One is fast pain and slow pain. So this is very commonly being used in your textbooks. So when you take fast pain, it can be again known as sharp pain, pricking pain, acute pain, or electric pain. So when you come across these terms, sharp pain, pricking pain, acute pain, or electric pain, that implies fast pain. It is felt when a needle is stuck into the skin, when the skin is cut with a knife, or when the skin is acutely burned, or when some person is subjected to an electrical shock. And also, it is not felt in most deep tissues of the body. It is found that fast pain travels in a different type of a nerve fiber, which is a large diameter nerve, which is A delta fibers, in a velocity between 6 to 30 milliseconds, and felt within about 0.1 seconds after a pain stimulus is applied. So very quickly. And they have found that glutamate is the neurotransmitter secreted at the spinal cord by these A delta pain nerve fiber endings to transmit these fast pain signals to your cerebral cortex. And in contrast to that, what is slow pain? Slow pain, there are different names being given again, like burning pain, aching pain, throbbing pain, nauseous pain, and chronic pain. So when you are having severe arthritis, that is a joint pain, and some kind of abscesses in your body, like skin abscess or dental abscess, then of course, you will come across or you will feel slow pain. Usually, because this is slow now, therefore, it begins only after 1 second or more, and travels in another type of nerve fiber, which is small diameter C fiber. The velocity is between 0.5 to 2 milliseconds and increases slowly over many seconds and sometimes even minutes. So what is the neurotransmitter here? There are two neurotransmitters being involved, that is glutamate and substance P. So these are the two neurotransmitters which are responsible to elicit slow pain. Right. So another classification is there. Now we have learned fast pain and slow pain. In contrast to that, there's another classification, that is acute pain and chronic pain. Another names being given, acute pain is also known as physiologic pain, and chronic pain is known as pathologic pain. So we will deal with this acute pain and chronic pain in later slides. Before that, we will learn something regarding the pain receptors. So what are the pain receptors? Pain receptors are free nerve endings. Remember that. So pain receptors, or pain is sensed by free nerve endings. They are found all over the body, especially in your superficial layers of your skin and internal tissues like periosteum, arterial walls, joint surfaces, and falx and tentorium in the cranial wall. And most other deep tissues are only very sparsely supplied with pain nerve endings. But the above mentioned things like superficial layers of skin and these internal tissues mentioned here are being widely supplied by free nerve endings. So there are three types of pain stimuli, either mechanical stimulus or a thermal stimulus, or else a chemical stimulus can cause or elicit pain sensation. So what are the chemicals which will cause pain or which will stimulate pain nerve endings. Those are bradykinin, serotonin. I think these are somewhat familiar with you all. Bradykinin, serotonin, histamine, potassium ions, some acids, acetylcholine, proteolytic enzymes, they will elicit or they will stimulate the free nerve endings. And according to some studies done, it is found that fast pain is elicited mainly by mechanical and thermal types of stimuli, while slow pain can be elicited by all the three types of stimuli, either mechanical, thermal, or chemical stimulations. Then, another very important feature of the pain receptor, or when I'm saying pain receptor, it indicates free nerve endings. So the adaptation, regarding the adaptation feature or the phenomenon, pain receptors adapt very little and sometimes not at all. This failure of pain receptors to adapt is important because it allows the pain to keep the person apprised of tissue damaging stimulus as long as it persists. So is it important? Yes, of course, because then we are aware of the alarming sign. Still, we are having an ongoing infection or maybe ongoing damaging thing within our body. Therefore, we can act accordingly very quickly. Otherwise, if these pain receptors adapt very quickly, what will happen? Stimulus will be there for a longer period, but we don't take any action regarding that. So it will cause maybe permanent damages to our body. Therefore, this failure to adapt or else slow, very slow, or maybe non-adaptation of pain receptors will be very important when you talk about our safety. So this non-adaptation or very less adapting feature will lead to another phenomenon that is known as hyperalgesia. In some conditions, what is this hyperalgesia? Excitation of pain fibers becomes progressively greater, especially like very slow, aching, nauseous pain as the pain stimulus continues. So this increase in sensitivity of the pain receptor is known as hyperalgesia. Right. Now, when you're talking about pain, the most important thing you should learn is pain pathway. Before that, I would like to recall your knowledge on spinal cord, a cross-section, the anatomical arrangement of a cross-section of the spinal cord. Because you know that we have, when you're talking about any of the ascending pathway, nerve pathway, we have three neurons. That is first order neuron, second order neuron, and third order neuron. So when you're talking about these three neurons, first you have to talk about the spinal cord. So usually the first order neuron lies, the cell body lies within this dorsal root ganglia. Then the central process will come and usually enter the spinal cord. And you know that spinal cord cross section, middle area is the central gray matter. Surrounding that, we have the peripheral white matter. So where is the gray matter? Where is the white matter? And where is the dorsal root ganglion? You should know. With that knowledge, then we will see what is the pathway which will carry the pain. Pain sensation is carried to the brain via lateral spinothalamic tract. So that is again a part of anterolateral spinothalamic tract. So this is lateral spinothalamic tract. So at the end of the lecture, you should know what is the first order neuron, what is the second order neuron, what is the third order neuron of the pain pathway. And what is the pathway? That is lateral spinothalamic tract. Right. Now we will move on to a small journey. That is, we are going towards the brain, starting from our pain receptors. Suppose now we have an injury, we have a cut injury with a knife, sharp knife, so fast pain, okay? So the pain receptor is free nerve ending. Then what will happen? pain impulses are transmitted to the spinal cord through two types of nerves. We have already known these things. Fast pain will be carried by A delta fibers, while slow pain will be carried by C fibers. And then what will happen? Axons will enter the spinal cord from the posterior root ganglion, where the cell body of the first order neuron lies. These fibers of the first order neuron, the central fiber, will terminate by synapsing with the cells of the posterior gray column of the spinal cord, including the cells of substantia gelatinosa. I think you know the layers of the posterior gray column of the spinal cord. So that is usually the lamina 2 is known as substantia gelatinosa. So that is the second order neuron. So the first order neuron, the central process comes and synapses, and then what will happen? The second order neuron starts at that point. And axons of this second order neuron now will cross obliquely. It will cross obliquely to the opposite side within the spinal cord in the anterior gray and white commissures in front of the central canal of the spinal cord within one spinal segment of the cord. And then what will happen? The second order neuron will ascend in the lateral spinothalamic tract. Where is this lateral spinothalamic tract? In the white column of the spinal cord. So many of the fibers of this lateral spinothalamic tract will end at the thalamus. So special nucleus in the thalamus that is known as ventral posterolateral nucleus of the thalamus. So that is the third order neuron. So many of the fibers of the lateral spinothalamic tract go and end or synapse within the third order neuron in the ventral posterolateral nucleus of the thalamus. Then starting the third order neuron. So axons of the third order neuron in the thalamus, now what will happen? They pass through the posterior limb of the internal capsule and corona radiata and entering the somatosensory cortex. So usually it enters to the somatosensory cortex 1. And from here, the information is transmitted to the other regions of the cerebral cortex to be used by the other motor areas and also somatosensory area 2 or the parietal association areas. So that is the overview of your pain pathway. So now when you talk about the pain pathway, now I told you as a small summary, just we'll quickly go through this one. First order neuron will lie at the posterior root ganglion and the central process then will enter the spinal cord and then synapse at the posterior gray column or the horn. There's many laminae there. So substantia gelatinosa is the second order neuron and then it will synapse with the cell body of the second order neuron at the substantia gelatinosa. Then the second order neuron, these axons will lie and then they will cross immediately obliquely to the opposite side in front of the central canal of the spinal cord in the anterior commissure. And then they will enter the contralateral white column and ascend to the cerebral cortex as the lateral spinothalamic tract. And then they will go, so that is the second order neuron, they will go and synapse at the thalamus, and then thalamus starts the third order neuron. Then from that, what will happen? Third order neuron, they will send axons to the somatosensory cortex 1, and then with that, it will communicate with somatosensory area 2 as well as the other area of the brain to perceive the pain stimulation. All right. Okay. Then another small thing I think you should know, fast pain impulses travel directly up to the ventral posterolateral nucleus of the thalamus and they are then relayed to the cerebral cortex. So that is a normal usual pathway, no? But majority of the slow pain fibers, which will be carried through C fibers, which again will ascend via the laterospinothalamic tract, will terminate, majority will terminate at the reticular formation, which then activates the entire nervous system. So that thing, that difference you should know. So almost all, I think most of the fast pain impulses will go as the usual pathway through the thalamus and to the somatosensory area, but majority of the slow pain fibers will end up at the reticular formation, and then they will activate the entire nervous system. So slight difference between fast pain and slow pain. All right, now when you talk about now we have learned about the normal ascending pathway, then the degree to which a person reacts to pain varies tremendously. That is very, I mean, you may have experienced that. Isn't that so? So one person will respond to a certain pain stimulus differently when you compare it with another patient's reaction, right? He will feel no pain, no very mild pain, but another person might feel it as a very severe pain. So that means the degree to which a person reacts to pain varies accordingly. So what is the cause for this variation? This results partly from capability of the brain itself to suppress input of pain signals to the nervous system by activating a pain controlling system. So we have a pain control system in our body, which is again known as analgesia system, or sometimes it is known as pain suppression system in the brain and the spinal cord. All right. So this one, this pain suppression or the analgesia system will cause different reactions of different responses of different people to a certain or particular type of pain stimulation. So this pain suppression or analgesia system is a very complex one, but a very brief idea about that will be enough for your knowledge. So you should know is this analgesia or pain suppression system consists of mainly three components. First one is, according to this picture, shows you periaqueductal, gray and periventricular areas of the mesencephalon and upper pons, this area. Can you see the mesencephalon? And then you have this periaqueductal, gray matter. So all surrounding this area, right, surrounding the aqueduct of Sylvius and portions of third and fourth ventricle will known as one part of a major part of the analgesia system. And the second component is Raffimagnus nucleus. Can you see this Raffimagnus nucleus? Okay, it is again in the pons. And then locally, there's pain inhibitory complex, which is located in the dorsal horns of the spinal cord itself. So pain inhibitory complex in the spinal cord itself, and nucleus Raffimagnus in the pons, as well as a collection of periaqueductal, gray and periventricular areas of mesencephalon and the upper pons area are the three components of analgesia system of the brain. Okay, pain suppression. So you should know analgesia means pain suppression, or we are removing pain. That is the very simpler form of simplified meaning of analgesia, right? So when you treat with some kind of drugs which can alleviate pain, those are known as analgesics. Okay, so that the name derived from this analgesia, meaning no pain. Can you understand? All right. They have found several neurotransmitter or maybe some substances which are involved in the analgesia system. Especially two substances being identified as mainly playing a role in the analgesia system. Those are enkephalin and serotonin. So fibers originating in this area send signals to the dorsal horn of the spinal cord, and they will secrete serotonin at their nerve endings. And what will this serotonin do? That serotonin causes local cord neurons to secrete enkephalin within the spinal cord. All right. So this enkephalin is believed to cause both presynaptic and postsynaptic inhibition of incoming type C and type A delta pain fibers where they synapse with the dorsal horns. So you should know that enkephalin and serotonin both have to be there to complete this analgesic system. Can you understand that? Mainly, serotonin will play a role from the central area, and then they will induce secretion of enkephalin within the local cord neurons, and enkephalin will then do inhibition of presynaptic and postsynaptic nerve fibers, which are incoming type C and A delta pain fibers, where they synapse with the dorsal horns. All right. Okay. So if you take a summary, quick summary of this analgesia system. Now this picture shows you again the analgesic pathway as well as the lateral spinothalamic pathway. This analgesic pathway is shown in red color. You can see that. And you can see it means the endogenous pain controlling system, right? So body has its own analgesia system in the brain, which provides a short-term relief. Until we take some analgesics, then we can have a short-term relief from pain without any medication. Has got its own pathway through which it blocks the synaptic transmission of pain sensation within the spinal cord. You can see that, right? Analgesic system, these nerve fibers come and they also synapse at the lateral spinothalamic, the second order neuron area of the lateral spinothalamic tract or the pain ascending pathway. This analgesic pathway also comes and synapse. All right. So there are two major neurotransmitters being involved there, that is serotonin and enkephalin. All right. And remember, analgesic drugs, like I will talk you about these analgesic drugs, especially there's a very commonly used one known as opioids, like pethidine or morphine, okay? They act through this system and provide a controlled pain relief. So opioids, the group of analgesics, will come and act through this analgesic system. They will give us support through our endogenous analgesic system to provide the controlled pain relief. All right? Okay. Then when you're talking about, now we have talked about pain pathway or the ascending main pain pathway, as well as we learned about our endogenous analgesic system. Now, the next one you should know is, you should know what is referred pain. So when you're going through the pain textbooks or pain theories, you will come across different names. The most important one is referred pain. I think you may have felt some kind of, not you, may have heard of something like a person who feels or who suffered from myocardial infarction or heart attack. Usually they say they have radiating pain along their left arm, the medial aspect of the left arm, they had the pain. But then you might think, okay, this may be, if you don't know about this referred pain concept, you might think, okay, there's something very simple, maybe due to muscular pain, okay, and maybe due to some tissue injury. Don't worry. But then patient might die within 1 or 2 hours, or maybe on the spot, he might die. Why? Because this may be the only sign or symptom of a severe myocardial infarction. All right. So what is the phenomenon? What is the concept behind this? How can the heart pain can be felt as radiating left upper arm pain? So again, this one comes into your mind. And if you have a diaphragmatic problem, diaphragmatic pain, this again can be felt as your tip of shoulder pain joint. Tip of your shoulder joint pain. All right. So what is this? Right now, if you have an appendicular pain, appendicitis, the pain is felt as periumbilical pain. So what is the concept? Here, the meaning or the cause for this is a referred pain. It is the pain that is perceived at a site adjacent to or away from the site of origin. So remember, the pain originates in a visceral organ, but is sensed at a somatic site. Somatic means something to do with your skin, and visceral means inside your internal organ. So when a pain originates in your viscera or your organ, one of your organs, but you can't feel it, right? You can feel it as a pain at a somatic or a skin site. All right. So deep pain and some visceral pains are referred to other areas. But remember, superficial pains do not refer like this, only deep pains. Some of the examples which you will come across very frequently, as I told you, 1 or 2 examples I have told you. Cardiac pain is felt as inner part of the left arm and also left shoulder. Pain in ovary is referred to as the umbilicus, right? Not only ovaries, as I told you, appendix also, it is appendicitis. It can be felt as umbilical pain. Pain from testes is felt in the abdomen. Diaphragm pain, which will be referred to your tip of the shoulder joint. Pain in gallbladder can be referred to the epigastric region, all right? And then renal pain is referred to your loin area. It will mislead the examiner or this physician unless he knows about these referred pain sites. Okay. So when you are going to your clinicals, you will be learned about all these things. I mean, at the very beginning, right? What are the sites of referred pain from different types of deep internal organs of our body? So that knowledge is very, very vital when you are examining patients. So what is the mechanism of this, right? So there's a concept or a very known theory for this one, how this concept has originated. That is convergence projection theory. Okay. So convergence projection theory means, now look at this picture, you can see visceral nerve fibers, that is nerve fibers which are originated from your organs, as well as skin nerve fibers. What are these skin nerve fibers? Where are they coming from? They are coming from the same dermatomal area. Okay. So they will come and converge in the same area of the spinal cord, right? So convergence of somatic and visceral pain fibers on the same second order neuron. Here's the second order neuron in the dorsal horn that project to the thalamus and then to the somatosensory cortex. Somatic and visceral neurons converge in the ipsilateral dorsal horn, right? When the visceral stimulus is prolonged, facilitation of activity from the somatic fiber nerve ending also occurs. Then brain, it will stimulate the second order neuron. And of course, brain can't determine whether this pain or the stimulus comes from either an organ or else from the skin region. Therefore, you feel, because now facilitation happens in your skin now because of this prolonged internal organ pain stimulation. Therefore, brain thinks this pain arises from your skin or the somatic area, which has the same dermatomal origin. That is why both these visceral and skin nerve fibers coming to the same second order neuron. And they are also going up in the same pathway, right? At the laterospinothalamic tract to your thalamus and then to your cerebral cortex. All right. So as an example, again, I'm taking the same example. Heart and inner aspect of the left arm originate from the same dermatome. So the pain is heart, pain in heart is referred to the left arm. So knowledge of the different types of referred pain is important in clinical diagnosis, because in many visceral ailments, the only clinical sign would be referred pain. All right. Then another thing, I told you there are different types of concepts and new names you should learn when you are going through pain pathway as well as pain physiology. Now, I don't know whether you have come across this phenomenon. Now, when you have a pain in your body, maybe your head or some area in your body, if you apply something and rub that area or shake that area, then you feel some kind of reduction of the pain sensation. So what is the rationale behind this one? You apply some small balm and then you just rub there, and most of the time we will get rid of that pain. Okay, maybe without any balm, if you just rub that area, you will feel some relief. So the phenomenon behind this, right, that is not a small simple thing. That is actually due to a very complex theory. That is the gate control mechanism of pain modulation. What is this gate control mechanism? Simultaneous activation. That means activation of cutaneous skin mechanoreceptors, touch sensation, right? Those are the cutaneous mechanoreceptors whose afferents emit collaterals, right, that terminate in the dorsal horn with this pain nerve endings. So stimulation of pain nerve endings, and at the same time you will activate the cutaneous or touch receptors, which will carry the touch sensation in the dorsal horn of the spinal cord. So the activity of these mechanosensitive afferents may reduce the responsiveness, okay, of dorsal horn neurons to their input from nociceptive afferent terminals. So there is two phenomena called closed gate status and as well as open gate state. We will see what is that, okay? And I don't know whether you have heard these things. Now, another special treatment option for very severe pain is known as TENS. What is the big name for TENS? That is transcutaneous electrical nerve stimulation. Again, it is like a electrical current, right? You just give a small nerve stimulation, TENS, for your pain inducing site. All right. So this method uses electrodes to activate A alpha as well as A beta fibers near the injury. That means which the fibers which will carry touch sensations will be simultaneously being stimulated by electrodes. Then what will happen? You have invariably your pain signal transmission, and then you are artificially stimulating A alpha and A beta fibers to carry touch sensation. So both these will then do something, or this gate control mechanism, to alleviate or to reduce pain. Okay. So according to this theory, painful information is projected to the supraspinal brain regions if the gate is open. Whereas painful stimulation is not felt if the gate is closed. Okay. So when you have the closed gate status, that is by simultaneous inhibitory impulses by the touch sensation. When the gate is open, what will happen? You will have, you will feel the pain, okay? And then the excess tactile stimulation will close the gate, and then you will not feel the pain. Then once you get out or take out your touch sensation or non-painful tactile stimulation, then what will happen? Your gate is open for pain. So when the gate is open, you will feel pain. When the gate is closed, you will not feel pain. So that is the gate control theory for pain modulation. So that is the basis behind decrease of pain sensation when you rub or when you massage a certain area near the area of injury, as well as this TENS treatment option. All right. Okay. So another very important thing you have to know is when you're talking about the treatment options of pain, you have to know about the chemical mediators in the pain pathway. Now look at this picture. When you have an injury, at the injury site, there are many chemicals being released. It will release bradykinin, serotonin, and also some kinds of mast cells will secrete histamine, okay? And then substance B will be released, as well as prostaglandins will be released by your endothelial area, all right? And all will contribute to inflammatory process. So the mechanisms of action of different substances will differ. Remember that all are not like same, but all will at the end ultimately will contribute to inflammatory process, especially these prostaglandins. Then they will activate the nociceptors. These all histamines and all these things will go and stimulate the pain pathway or the nociceptors. By stimulating the nociceptors, they will activate the lateral spinothalamic tract. So now you may have heard, when you have a pain, right, very strong pain, you will be treated with, if it is not being alleviated by using paracetamol, then you have to use non-steroidal anti-inflammatory drugs or NSAIDs, right? Some kind of, another example is aspirin, right? And other NSAIDs. So what is the basis of this one? Prostaglandin E2, right? A variant of prostaglandin. It's actually a cyclooxygenase metabolite of arachidonic acid. Remember, these NSAIDs will deactivate the cyclooxygenase enzyme, which will be important for the cyclooxygenase pathway. So if you will be given with this NSAIDs or aspirin, what will happen? Prostaglandin E2 will not be produced. Now, as this picture shows you, you know that prostaglandin E2 is a mediator of pain production. Therefore, what will happen if you cut off that thing and if you not allow the prostaglandin to be made at the site by giving this NSAID, then this mediation of pain pathway will not occur at a very higher rate. Therefore, you will not have pain for a certain period until this drug is active. Okay, so that is the theory behind prostaglandin E2 as well as giving NSAIDs to treat the pain sensation. Okay, so you should be aware of this one very well when you are talking about pain physiology, right? Okay, then another one I told you at the beginning of my lecture as well. What are opioids? Pethidine, morphine are actually artificial opioids, right, which we will give as exogenous drugs. These are commonly used analgesics that can exert their effects at various places of the central nervous system, including the spinal cord and the dorsal root ganglia. Now, when you are looking at this picture, you can understand that opioid, now when you have the control and this opioid, if you give an opioid or endogenous opioids are also there, various modes of action of opioids are there to decrease the nociceptive transmission. It is again having multiple sites of action. There are interneurons in the superficial regions of the dorsal horn that contain endogenous opioid peptides. So what are these endogenous opioid peptides? To name few, enkephalines and dynorphin, like morphine, okay? So these interneurons terminate in the region of the dorsal horn of the spinal cord, where nociceptive afferent terminate, right? As I told you earlier also, I told you that analgesic system, endogenous analgesic system of our body is going to act with the help of or in coordination with these opioids, okay? So now you can see that these interneurons, right, they will terminate, which will secrete or which will carry endogenous opioid receptor or these peptides. They will terminate in the region of dorsal horn, where the nociceptive afferents will come and terminate, right? So opioid receptors are located on the terminals of nociceptive fibers and on dendrites of dorsal horn neurons, allowing for both presynaptic and postsynaptic sites of action for opioids. All right, so that is the action of opioids. So you should be able to learn, or you should be able to understand actions of opioids as well as NSAIDs to treat pain when you are going through your pain physiology. All right. Right. Now, when you come across, now we have learned great details about physiological aspect of pain. And now you should know the clinical abnormalities of pain. Now, hyperalgesia, I think you have come across this word earlier also. Hyperalgesia and hypersensitivity to pain. When the pain pathway is excessively excitable, okay, it will give rise to hyperalgesia. There are two types of hyperalgesias, that is either primary hyperalgesia or secondary hyperalgesia. Here I am just only mentioning the brief introduction about these ones, but when you have time and if you are interested, you can go through these ones and you can find more details. Okay. And when you have excessive sensitivity of the pain receptors itself, you will have primary hyperalgesia. And suppose if you have facilitation, increased facilitation of the sensory transmission, pain transmission, then of course you have secondary hyperalgesia. All right. And this one, I think some may have experienced this disorder. This is known as herpes zoster, because this is something to do with severe pain, right? Unbearable pain. Another very common name is shingles. Okay. What is the meaning and what is the basis for this is if you have had an episode of chicken pox, okay, and then they have found that varicella zoster, okay, this herpes virus, okay, or varicella zoster, that virus can latently, right, they can latently reside in the dorsal root ganglion area, right, in the spinal cord for a long period. And if you have if you are coming across a very immune suppressed status, one day in your life, what will happen? This latent varicella zoster virus in the posterior root ganglion will be reactivated and it will infect the dorsal root ganglion. So it will cause severe infection and severe pain in the dermatomal segment subserved by the ganglion. So what will happen? Ultimately, it will elicit a segmental type of pain, right, around the dermatomal distribution, which will be covered by that dorsal root ganglion, that area, and it circles halfway around the body. So this, and also you will have some eruptions like blisters appearance, right, according to a dermatomal pattern, and also very severe pain. So characteristic pain with these characteristic eruptions, blister eruption, these are the hallmark of shingles or herpes zoster. This is again due to some kind of, the pain is due to reactivation of herpes virus and it will infect the dorsal root ganglion and then it will stimulate our pain pathway. And what is this one? Another very interesting phenomenon, that is allodynia. What is allodynia? It is a sensation of pain in response to a normally inchoate stimulus, normally innocent stimulus, right? Now, suppose if you are having a bath, okay, and warm water touches your skin, right? If you are having a warm shower and after you are having a sunburn, right? After you are spending long hours in outside and then coming and having a warm shower, then what will happen? Because of this sunburn, your body, these free nerve endings, all these things are being exposed to some kind of damage has occurred. But you can't feel it at the normal status. But when you come and having a warm shower, that warm stimulation earlier day has not caused any damage or any pain stimulation to your body. It is so peaceful and it is very soothing for you all. Isn't that so? But when the sunburn has occurred and damaged your and exposed your free nerve endings, maybe what has happened is warm stimulation, warm shower will cause painful sensation to your skin, right? So the fault is not because of warm shower, That is because of the sunburn has damaged your skin and exposed your free nerve endings maybe. So that condition is known as allodynia. Maybe if you are touching your skin with a feathery thing as shown in this picture, then you will feel pain. That is very, very rare phenomenon. No, it's not so. Otherwise, if you are touching with a very soft thing like a feather or a cotton wool, you will feel very soft, right? But in this case, they will feel pain when they are touched with very innocent stimulations. Right. Now, in the beginning of my lecture, I told you there are different types of classifications of pain. One is acute pain and chronic pain, right? So acute pain is usually physiologic and chronic pain is pathologic. Why? Chronic pain means it is often refractory to conventional therapies like opioids and NSAIDs. Now we have learned about what are opioids and what are NSAIDs. This is actually either due to a neuropathic, right? Something related to nerves pain, or else due to an inflammation. Now neuropathic pain, right? We will take this neuropathic pain and learn about chronic pain using that neuropathic pain. Occurs when nerve fibers are injured. Neuropathic pain is unbearable, and when you have it only, you can tell the experience. It causes, the nerve damage will cause and exert an inflammatory response, and this is due to activation of microglia in the spinal cord. And it is very difficult to treat. Maybe the pain lasts for a long period, like diabetic neuropathy and ischemic neuropathy, or else maybe some kind of ischemic damage to your nerves. It will induce neuropathy and toxin-induced nerve damage. So I told you normal NSAIDs and normal opioids, normal conventional therapies cannot cure the chronic pain. So some therapies, newer therapies, have been found to focus on synaptic transmission in central nociceptive pathways and also peripheral sensory transduction mechanisms. So many are still being under researched, but there are few drugs have been taken as or have been come to your clinical practice as very efficient drugs to treat this chronic pain. The first one is capsaicin transdermal patches or creams. Okay, when you talk about pain pathway, there are different types of receptors. Okay, within your spinal cord and throughout your spinal cord, this pain pathway. One is capsaicin receptor TRPV1. So this one is known to be activated by heat and protons and products of inflammation. Okay, and they say by using these transdermal patches and creams that will reduce pain by exhausting supply or reducing supply of substance P in the nerves, right? So there's some very, complex mechanism under this one, but you should know is there are different types of receptor blockers, which are known as capsaicin receptor or TRPV1. They can be blocked by using these transdermal patches or creams. And the second one is lidocaine, right? Another important sodium channel, which is known as NaV1.8, is a tetrodotoxin resistant voltage gated sodium channel, and it is associated with nociceptive neurons in the dorsal root ganglia. Okay, this receptor or this channel. So if you block, right, by using lidocaine and mexiltane, if you block these channels, sodium channels, then what will happen? You will not feel pain. And another one is very commonly used these days for your severe neuropathic pain, that is gabapentin. Again, it is an analog of GABA. I think you may have heard about GABA, right? It is a neurotransmitter, inhibitor neurotransmitter, and it acts on voltage-gated sodium channels. All right. So these are the drugs which will be taken or which will be used to treat chronic pain. So you should know the drug as well as you should know what is the basis behind this one, what is the channel which is being inhibited, what is the neurotransmitter, or what is the receptor being blocked by these drugs, you have to know. Okay, right. So I think with that clinical implications and a little bit of pharmacological knowledge, now we have come to our end. I think at the end of the lecture, you are very thorough with different types of pain, right? Other than this, I think you can go through your textbooks and find out what are the differences between visceral pain and peripheral pain, okay? And then nociceptors, free nerve endings are the nociceptors, and you should know about a little bit of nociceptors, and differences between fast pain and slow pain. And you have to know great details about pain pathway, ascending pathway, as well as the endogenous analgesic pathway. And then phenomenons of referred pain, and also that is convergence facilitation theory, as well as gate control mechanism as a modulatory pathway, right? And then treatment options, right? Conventional treatments, the mechanism of action, that is opioids and NSAIDs and prostaglandin. And also you should know about chronic pain, such as neuropathic pain, and some drugs which will be used to treat neuropathic or chronic pain, and basis, simplified versions of basis behind these treatment options. All right, so if you know all these things, I think it will be very easy when you are going through your clinicals, and when you are finding patients with severe pain, then it will be easier to understand how to treat these patients. All right, okay, all the very best, and see you soon with the new lecture. Bye.